Hey everyone, welcome back to Medfoxes. This is part 2 of our pacing leads series in cardiac pacemakers, a beginner's guide. Let's pick up where we left off and continue exploring pacing leads. In this part, I'll be starting with the electrodes, so let's dive right in. The primary purpose of lead electrode is to act as long-term interface between the lead and myocardium. It is through this interface that the electrical stimulus passes. The other purpose for the electrode is to sense intracardiac signals for the pacemaker to monitor to ensure proper pacing when necessary. To give optimal performance, an electrode should have a certain factors, which include low stable threshold for longevity and safety, high pacing impedance for longevity, low source impedance, and good sensing of intrinsic electrical signals from cardiac depolarization and not electrical signals from other sources. The factor that impact the electrode performance will be discussed in following slides. They are fixation mechanism, polarity, surface material, size, surface structure, and steroid elution. There are two types of fixation mechanism, passive and active. Passive fixation in relation to endocardial leads means that no part of the lead itself is actually embedded in the endocardium. Rather, the lead tip is trapped within the trabeculae and or held in the position by itself by its preformed shape. Example, J lead in the atrium. Passive fixation leads commonly uses tines or fines to catch trabeculae in the heart, or the lead is canted or curved to help place and hold the lead tip in certain position. Passive anchoring devices such as phalanges or wedge tip cages and balloons were early attempt to solve the dislodgement problem of early pacing. However, only after Tynes leads were introduced by Medtronic in 1976 did a true solution to dislodgement emerge with regard to passive fixation. Today, there is approximately a 1 to 2 percentage dislodgement rate with passive fixation leads, 1 to 2 percentage in the atria and 1 to 2 percentage in the ventricle. The tines dislodge within the trabeculae of the heart and provide accurate, acute and chronic stable electrode anchoring. Most patients have well-developed trabeculae in their ventricle. In atrium, only the appendage is trabeculated. Therefore, a preformed J-shaped passive fixation lead is required. Active fixation mechanism. Active fixation means that part of the lead actually embeds in the heart tissue for fixation via screw and helix electrode, which is extendable, retractable, and fixed screw mechanism are most common active fixation methods. Fixed screw leads provide excellent stability. The lead body must be turned in the counterclockwise rotation during insertion of the lead. Sense mapping can be done prior to fixing the screw to the myocardium. The lead body is then turned into clockwise rotation to fix the screw to the myocardium. Extendable, retractable screw-in leads provide excellent stability. The screw is retracted to prevent damage to the veins and cardiac structure during lead advancements. The ability to retract the screw makes entanglement in cardiac structures less likely. The screw is retracted during transvenous introduction and during sense mapping. and extend for the lead fixation. Care must be taken not to overextend or over retract the screw with this type of screw mechanisms. Today, there is approximately a 1 to 4% dislodgement lead with active fixation lead is noted. 1 to 4% in the atrium and less than 1% in the ventricles. You can see the active fixation. You can see the active fixation lead with extended helix at the tip in this diagram, in this picture. Active fixation application. Active fixation leads screw into myocardium and provides stable, acute and chronic electrode anchoring. This fixation mechanism is ideal for patients with smooth ventricle walls and for the atrium when the appendage is missing in case of coronary artery bypass grafting or malformed. These leads are also used for pacing sites other than the apex of the ventricle or the atrial appendage, example RUOT and septal wall pacing. This image shows a fluorovisibility of passive fixation leads. We can see the tines at the tip of the leads. This image shows the screw-in lead under normal fluoroscopic condition. You will notice the space is present when the helix is retracted as pointed out in the slide above. So this gap is used as a marker to confirm the helix is extended into the myocardium or helix is out of the lead tip. This slide shows various epicardial fixation leads. These fixation leads are commonly used in the myocardial and epicardial insertion. Myocardial epicardial leads require open chest tunneling or minimal invasive subxiphoid to attach the lead tip to the outside of the heart. They are used in special situations such as pediatric applications, congenital malformation, when mechanical heart valve is present, where multiple abundant endocardial leads are present, or concurrent with open chest surgery. Strap-in and screw-in leads are considered myocardial leads because they are attached to the outside of the heart and the hook electrode and the screw electrodes actually pass into the myocardium when fixed. Suture-on lead are considered epicardial leads because the electrode is attached to the outside of the heart and does not penetrate the myocardium. Design characteristics related to surface material of electrode are reviewed in the following slides. Many electrically conductive materials have been used for the surface material of pacing electrodes. Platinum and activated carbon are used extensively in today's lead electrodes because they exhibit the favorable properties of being corrosion resistant, biocompatible, and low polarization. Electrode performance stability is compromised if there is a surface corrosion. Biocompatibility in vivo means that the inflammatory response to the foreign object, example the electrode in this case is reduced. Biocompatibility helps stabilize electrode performance. Some materials exhibit more polarization at the electrode surface. Polarization is a buildup of opposite charge electrodes on electrode surface. Okay, it opposes current flow across the electrode surface into the surface myocardial tissues. Distal tip electrode size affects pacing and sensing performance. The next factor which impact the electrode performance, what we are going to see is the electrode size. Reducing the electrode size increases pacing impedance. Pacing impedance is the resistance to current flow from which the pulse generated to myocardial tissue. Pacing impedance is inversely proportional to current drain. With higher pacing impedance, there is a reduction in battery current drain. This ultimately translates into increased battery longevity. As the impedance is increased by reducing the electrode size or geometric surface area, the average geometric surface area of electrode has decreased significantly in recent years. At one time, most electrode had a geometric surface area of about 50 square meters. Newer electrode have a geometric surface area of 1.2 to 8 square millimeters. This decrease in geometric surface area has contributed significantly to pacing system efficacy. As the geometric surface area decreases, the impedance and the electrode tip is shown in the as shown in the graph. You can see in this graph, as the size of the electrode is decreased from 6 millimeter square to 1, and the impedance is gradually increased and reaches 1500 at a size of 1 millimeter square. Increased impedance at the tip electrode deliver energy more efficiently, thus allowing low output voltage settings that still reliably trigger cardiac depolarization. This lower voltage requirement reduces the battery drain, resulting in greater system longevity. Unfortunately, simply reducing the electrode size is not the final answer. Decreased size will also increase polarization at the electrode tip due to smaller surface area. When electrical current flows, the tip electrode attracts positively charged ion. Initially, the movement of this charged ion results in flow of current from electrode to myocardium. As, as the current pulse is continuous, a charged layer around the tip electrode and produce a capacitive effect. The capacitive effect refers to the buildup of a layer of charge electrode called polarization. Polarization impedes current flow from the electrode into the tissue. When polarization is excessive, a substantial amount of lead current must be used to overcome it, and less current is available for stimulation of myocardium. As a consequence, the output voltage must be increased and more lead current is required to maintain an adequate tip electrode voltage and a 2:1 safety margin. This high polarization can be overcome by changing the surface structure of electrode as discussed in following slides. Design characteristics related to the surface structure of electrode are reviewed in following slide. A smaller geometric size can increase impedance, but as we have seen it can also increase the polarization. By altering the surface structure to be more porous, you can increase the geometric surface area of the electrode and therefore lower the polarization. The platinized porous electrode have larger functional surface area. The collective spaces within the electrode porous make up the larger functional surface area, which control polarization for this geometric smaller electrodes. In summary, smaller geometric size, larger functional surface area. Benefits of a porous electrode surface include porosity increases the functional surface area of electrode, which reduces polarization. Consequently, more of the output voltage appears at the tip electrode. Porous electrode with a large functional area for surface area provide more electrode area for sensing. Sensing is therefore enhanced with functional surface areas. Tissue ingrowth within the porous structure stabilize the electrode position. Stabilization provide a reliable electrode myocardial contact, which is essential for efficient performance. In summary, when the electrode size is reduced, impedance increase, leading to improved longevity. When the surface area of the smaller electrode is increased through increased porosity, polarization is reduced, again increasing the longevity of the system. In this section, a discussion of steroid elution is considered. This includes the various types of steroid elution as well as the benefits. The benefits are considered as at both acute and chronic phases in the lead maturation processes. In summary, fixation mechanism, two category of endocardial leads, active and passive, which stabilize the electrode position. There are two polarities, unipolar and bipolar leads. Surface materials make the electrodes more corrosion resistant and biocompatibility. They exhibit less polarization. These features help to stabilize the electrode electrical performance. Size in sense, smaller electrode increase impedance with reduced current drain resulting in increased pacing system longevity. Surface structure, porous electrodes reduce the polarization of and enhance sensing. Steroid elution improves biocompatibility to low chronic stimulation threshold, virtually no threshold peaking, consistent sensing in both chambers. Lead environment is hostile and lead must be designed to meet hostile conditions. Leads are complex because of the many special components designed to withstand the rigors of the human body. Lead performance depends on how robust the lead is combined with successful implanting techniques.
You've just completed another vital step in understanding cardiac pacing. Let's keep the momentum going. We'll be exploring more essential topics in rhythm management devices in the upcoming videos. And now it's your turn to check your progress. Head over to our website where we've built two assessment tools just for you: a knowledge assessment with 500 plus MCQs from the entire Beginner's Guide series, and IBHRE format exam simulation consist of 5 blocks, 40 questions on each block, time to help you sharpen your time management for the real exam. Whether you're studying for IBHRE, CCI, EHRA, or simply want to sharpen your clinical understanding, these assessments are your next step. Click the link in the description to get started now. If you're enjoying this series, like, share, and subscribe to Medfoxes. It really helps us grow and reach more learners. Thanks for watching, and I'll see you in the next one.